Everyone, welcome. Thank you for joining us on today's episode of ACE Audio. A couple of new faces joining me today for a chat. We've got Dalton Yates and Amanda Kilminster, who are joining us for today's episode. We're going to talk today about the things we wish we were taught when we're at school, and that's practitioner school. So university, TAFE, college, whatever it might be. I've got Dalton and Amanda here with me. We're in Sydney at the moment teaching a dry needling course. Dalton and Amanda are both ACE trainee teachers. Working towards being teachers with ACE, and it's great to spend weekends like this together, sharing, learning, teaching. So thanks, guys, for joining me.
Thank you.
These two are also really great practitioners who bring their own experience, their own knowledge, and so it's great for them to be able to reflect in this chat about the things that they've learned along their journey that they wish they may have learned earlier. Yeah? Maybe give you a bit more of a head start to where you are now.
That's it, yeah.
So, Dalton, what's your first one?
My first one is what we often call the B to the Y. So if we look at point A being either identifying a trigger point, a dysfunctional movement, ability, anything at all, and Z being resolution of that pathology or pain or complaint that the client is having, what's the mechanisms or what's the process happening when we apply some sort of stimulus or some sort of modality? And this is going to lead into a few different sort of changes, I guess, in terms of taking a shift from a therapist-centered process to a client-centered process.
Right.
Because if we can understand that either the ischemic pressure or some joint mobilization or manipulation or dry needling is a resolution to, let's use trigger points as an example, we could also have those same resolutions occur through exercise, through stretching, through self-mobilization. So we could empower the client to take a choice of what they want to make change.
More than one way to skin the cat.
Yeah, exactly right.
Right. And so what you're saying there, let me get this right, is that there's different ways to achieve what we achieve.
Yeah.
And if we jump from A to Z, we think that the thing that we did is the only way that we get to the end result, right?
Yeah.
But there's lots of mechanisms in the middle, and lots of things can achieve those mechanisms.
Exactly right, yeah. The more that you understand those mechanisms for the particular modality that you're practicing, no matter what modality you work in, the more you start to realise, okay, this is overlapping with so much more that the client can take control of or that another therapist could take control of.
Gotcha.
Yeah.
Yeah, right. And how do you think learning that earlier might have helped or changed what you've done now?
It gives you more of a focus, and one thing we also have a chat about is this idea of lenses. So instead of, for myself as a remedial therapist, looking at something just purely musculoskeletal, it gives you that opportunity of, okay, maybe a manipulation would work here as well. Some excitation of these unisegmental muscles could lead to decreased tone in the muscles that I'm looking at working on.
Mm-hmm.
So yeah, it sort of, I guess, broadens what you can see as beneficial for the client.
Yep.
And then takes the focus away from yourself or myself. It's at the start of my career working, takes the focus away from me being the resolution for the client.
Right. Which is a bit scary, isn't it, as a practitioner? Like, you want to be part of that solution. In fact, a lot of people might want themselves to be the center of that solution.
Yeah.
You know, from a business model, from a self-importance model in their career, all these things, you want to be important, right, as part of that process. But so what you're saying is that, if you can remove yourself as the central focus and maybe put the patient in the middle.
That's right. Yeah,
cool. Interesting. Very good. Amanda, what do you got for us?
Dalton and I were talking earlier about the power of the language that we use with our patients. And really we have the ability to help someone to get better, but we also have the ability to hinder someone from getting better, depending on the kind of language that we use with them.
Yeah, right. And so do you think you've learned more about that over time, or is it something that happened just gradually, or it's more recent? What's that?
It's a little bit of both. Working together with you guys and us talking about the positive effects we can have on someone. I think I've learned a lot of things from Bo. He's really broadened my mindset on the way he looks at things in terms of what we tell a patient, how we tell a patient things. I think when we were in Thailand, we had a really good session where we were trying to make things fun for the client, giving them at-home things to do, and then talked about the language we use with them to make them understand that they can do things that they think they can't. But if we were to send them home telling them that, but it might hurt or it might make you feel a little bit worse, they're not going to go home and want to do the set exercise we've told them to do, because they're thinking, oh, but if I do that, it might hurt.
Yeah.
But if we send them home, we've done the exercise with them, they felt no pain doing it, and we send them home going, see what you are capable of doing.
Yeah.
They are more likely to then go home and do that and not experience pain while they're doing it.
Empowers them, doesn't it?
Yeah. So there was something learned over time, but I think more recently, I suppose we understand pain a little bit better these days. So yeah, it's been a gradual thing, but it would have been really good to have known that years ago, because I look back at some of the things I used to tell my patients or say to them when they're on the table, and I slap myself for it now, because I can't believe how many people must be walking around feeling that they have to have a treatment to feel well.
Well, you've been in this industry for about 20 years, and I don't think we knew 20 years ago how important language was, to be honest. So I've been around for a while too, and I was not taught that stuff.
No.
And it's only more recent years that I myself have also sort of better understood that. And you look back and reflect and go, wow, the stuff that I said to people really was not the best thing that I could have done for them.
Yeah.
And now that we better understand it, we can make more strategic decisions about the words we use and try to gear that towards the outcomes we're looking for, not just like, here, go and do this. Don't move when it hurts. Avoid this thing, avoid that thing. Like, no, that's not the most effective way to use words.
No. I think as well the way that we educate our patients, we educate their language, we change their language on these.
Yep.
A doctor 20 years ago told them they slipped a disc and they'll always have back pain. Helping to re-educate someone in their language.
Yeah.
I'm in pain now, but I can get better, as opposed to I'm in pain now and I'm going to have this for the rest of my life. Very, very different dialogue. But if they're using I will always be in pain, then the mind can control that. Yes, you will always be in pain, but we have the ability to get well. So if we can retrain a patient's language about their pain, then it makes endless changes that, I just had no idea that was something that was a thing.
Yeah. And I think not just language, but the extension of that is education. Like, yes, I'm going to use the right words, but I'm also going to educate you about the reality of your situation. The reality is hope in all situations. And I think that anyone that listens to these episodes will know that we talk about this a lot, but if you tell somebody a diagnosis, if you give somebody a diagnosis or a name, they will create meaning around that regardless of what it actually means. And so if we say you've got XYZ syndrome, whatever it might be, what that actually means is these symptoms are present. Here's the mechanism that caused it. Here are the things that can move you away from that. Here's how you get a resolution. And you take them on that journey of education, as opposed to saying, here's your scan, you've got osteoarthritis, off you go. Here's the pill, take this pill. People go away and go, what does that actually mean? Let me Google that. Degenerative joint disease. My joints are degenerating, like breaking, decomposing. And they'll create a story around it. And so, yes, using the right words, but also educating people so that they have a better understanding, so they don't make up their own story around their presentation. So,
and how many times do we have the conversation about people being told, well, you've got arthritis in your spine? If we were to scan most people over 40, majority of them are going to have some form of arthritis in their spine. Arthritis doesn't equal pain. But to the average person, they think arthritis and they think pain.
Yeah.
So if we can educate someone on those sorts of things, it makes a huge difference to the way they think about their pain.
For sure. Definitely. So, what you got?
Lovely. So my next one is neurophysiology, and this is something that I'm still in the midst of sort of working through. So I haven't really got a fantastic understanding and grasp of this yet, and only just really starting to respect how big this is in clinic and presentations. So any sort of neuro sort of screening assessments, neuroanatomy, understanding the pathways or innovations of common muscles, joints, or muscles and joints that you work with. If you can understand the neuroscience behind that, the change in the treatments that you can do is amazing, in terms of one that we commonly talk about with dry needling in our dry needling workshops is segmental inhibition of commonly innervated muscles. So getting a better understanding of that, can we use that? Can we utilize that in our treatments? And that's something that I think a lot of professions, a lot of modalities don't spend a lot of time on.
It's true. Yeah. Look, I've got a degree. I've got other qualifications. And neurophysiology, neuroanatomy was lacking in all of the studies that I've done. I think that's a pretty consistent message for most people that we speak to, is like, we didn't cover it enough or well enough. And I would argue that you, when you say you don't have a good grasp of it just yet, I'd say you do, because I've seen what you know. But yeah, maybe from where you started to where you are now has been a big jump. But
Yeah.
I would be on the same boat with you there. Had I known that stuff earlier, we'd be much further down the road as practitioners.
100%.
Yeah, good one.
I think the other one that I was thinking of was the emotional and mental toll that being a manual therapist can have. We talk a lot about the physical toll.
Yep.
We would have had most of our lecturers say, don't head out there and take a job on that's going to expect you to do 8 hours of massage or physio or whatever a day, 5 days a week, because you're going to burn out. And so we all had that in our mind, but I don't think anyone, I know they didn't for me, no one really spoke about the emotional and mental toll that working with other people day in, day out, that kind of a toll that it can have on us as well, that mental burnout and emotional burnout, it's just as real as the physical burnout.
Yeah. Do you think over your journey you've learned to manage that by default? Or did you have to kind of get a little bit burnt out first to recognise it?
100% had to burn out first.
Right.
Because we discussed that today. Most manual therapists take on this role because we want to help people. We no one wants to touch people because it's like we do this because we want to help people. That's what we're out there to do. And so when someone's in even emotional pain, so they're offloading their problems onto us as well, talking to us about their issues as well as their physical problems, we naturally want to help them with that as well. A lot of us are empaths, so that's what we want to do. And so we have these people that are coming to see us and they're telling us all of their problems. It's exhausting, but we don't want to say, well, don't talk to me about that, or because we want to help them with that too. The problem with that is we're allowing this to go on and on and on, and eventually it just becomes too much for us to cope with. And so, like you were saying before, 20 years later, you've picked up the tips and the tricks and the tools of the trade to work out how to very kindly say, maybe we need to refer you on to a psychologist or a counsellor, or, we've got ways that we can maybe steer a conversation away from something that we don't think is appropriate for us to be listening to. But that's their skills you learn over time. But if it was something that could be taught, that might save a lot of people from that burnout that does come from the emotional stress.
It's funny, I used to work in a clinic with a psychologist, and she told me that as part of her professional development, she has to get regular sessions with another psychologist. They have to sit down and one will play the therapist, one will play the patient, and then they might swap in another session, but they have to actually get counselling themselves so that they can manage all of the stuff that their patients dump on them. Yeah. And it's a shame that we have to kind of consider ourselves as a dumping ground for a lot of that stuff. It'd be nice to be able to absorb and deflect, but it's not always possible, is it?
No.
And it's a challenge. And I think you're right. Some people are better at it than others naturally, just through their own personality. And then there'll be some that will literally just be a big sponge. Give me your problems, I'll hold it for you. And that can be a real strategy for disaster, I think.
Yeah.
Personally, it's interesting, is like you said, that you naturally kind of absorb that with a lot of people. I think I personally have been able to sit separate to it, but there'll be certain patients that get you, like they really hit you hard.
Yeah.
And you walk away and you go, God, I'm exhausted from that, or I feel so strongly about your situation that I'm almost feeling your pain for you, and it's hard to do it all the time. So
yeah,
right. So that's that can be a career-ending problem.
Yeah, absolutely.
If you don't do it well.
Yeah. And it's unfortunately, it's a part of what comes with our job too, because we put our patients into a situation where it is quite a vulnerable position for someone. Like we were saying last night, you've got a complete stranger that you've met 5 minutes ago has come into your clinic, and you're now going to ask them if you can touch them. Like that's not a normal environment outside of the clinic room. And so already we're building a rapport with that person beyond what the average person would in that short frame of time. And then, we're asking them personal questions about their life because we need to get an overall picture of what job they have and what kind of lifestyle they have, because we need to know as manual therapists, are these underlying causes to your physical problem? But to the patient, we're showing personal interest about their life. And so they feel a friendship is forming. And in a friendship, you do talk to people about your problems and you share, exactly. It just gets to the stage sometimes that people share that little bit too much. And maybe that's the space that they need. You're the only person who's given them an hour of time and asked them genuinely, how are you today? Yeah. And if that's what they need to do, that's what they need to do. But I just did not have the skills for a lot of years to know how to properly deal with that much emotional incoming.
Yeah, for sure.
Yeah.
It's true, isn't it? Like we were talking about this earlier, but like the confessional booth, that is the massage table face cradle hole. Like regardless of what type of practitioner you are, if you've got a patient laying face down on the table in a vulnerable state, probably or partially undressed, and you're doing things to their body that make them feel nice and comfortable and safe, the chances are they're going to open up.
Yeah.
And they're going to tell you things because they can't look you in the eye. It's very much like that Catholic Church confessional. Like the priest is on the other side of the wall, that you can't see each other's face. You can say what you want without fear of judgment, and they will absolve you of your sins.
Yeah.
And that's where we're sort of by default taking on that role. So that can be
naked,
tricky.
I'm feeling $1 million and you're standing there
Yeah, like
I'm exhausted. Yeah.
What just happened? I didn't need to know all that stuff. Yeah, so that's a big one. And you feel like you can manage it now?
Yeah, I mean, age helps. I started when I was 17.
Mm-hmm.
I did not have the emotional maturity to deal with any of that stuff back then.
Yeah.
But as you go through your own life experiences and you've learnt your own skills of how to deal with more mature emotions, you do then know how to deal with that with other people. So I think getting into this industry later in life would mean you probably have more skills to deal with that than you would if you start younger. But yeah, I would say now. I mean, sometimes I allow someone to overstep because I have a patient that I really genuinely like them, I care about them, and then something terrible happens, like their mother dies or something. I do find that I'll be quite emotional because I care for that person.
Yeah.
You can't stop that from happening, but I think I have the ability now to close my clinic door and leave that there. Whereas before I could be laying awake at night worrying about my patients. And if you've got a day of 6, 7, 8 patients that came through and they were all going through major trauma of some kind and they've left that with you, that can be exhausting to lie in bed at 2 a.m. worrying about 8 different people's problems. Yeah.
Absolutely.
I think with that one as well, not even the sort of emotional baggage that clients might leave on the table for you to manage and put away, just the idea of going through client after client and coming up with assessments, treatment plans, going through differential diagnostics and working out how are we going to get this person better. That's what I find hugely exhausting in my treatments. Isn't what I'm physically doing or showing or teaching. It's that thought process, and that's where I burn out quickest as well.
The mental toll of the clinical reason.
Yeah,
that's right. So I like to try and keep it fairly short, no more than 4 clients in a row. If it's any more than that clinical reasoning starts to, I feel, take a bit of a dive down, and I don't think that's beneficial at all.
It's interesting. Like that's a strategy for you, like 4 and then a break and then 4 and then a break. Yeah, that works. I speak to a lot of practitioners who work in a setting where they're not able to, or maybe don't have the skills yet to apply a lot of clinical reasoning, and they're the ones that also burn out quickly.
Yeah.
Because they're not being challenged.
Yeah.
They're like they're in a setting where they're almost on autopilot, just doing the same thing. The same patient's coming in, they're expecting the same situation that they've been providing them, the same treatment they've been providing for the longest time, and they're just doing without thinking.
Yeah.
And the doing without thinking seems to be a common theme amongst practitioners who like, I'm not inspired by this anymore, I don't love it, I'm thinking about changing careers. And then you'll ask them what sort of patients you're seeing, like how you're working. They're like, it's the same sort of stuff every day. Well, no wonder. Like, it doesn't matter what the job is. If you're stuck in tedium, if you're in a rut, then you'll get stuck. You'll want to get out of there. But likewise, the opposite is too much of that can burn you down too.
Yeah, definitely.
What do you think the solution is to that? Because imagine yourself in 5 years' time where you're treating a lot of patients at a higher level, more clinical reasoning, and you want to be able to work more hours than say you could if with those 4-hour breaks, 4-hour sessions with breaks.
Yeah, definitely. So I think with this, like, one, let's just sort of, I guess, look at what is that number for the individual. For me, I've found that it is 4. And it is more so like if I do a 4-hour block, but there's a couple of half hours or seeing multiple clients within an hour, that is much more taxing for me than if I were to see 4 people over 4 hours. So it's sort of, I guess, engaging in that rapport with the client as well, and working through each individual case. So that's just what I've found personally. I know clinicians and therapists that can just hammer it out and have good quality work and good quality clinical reasoning skills and advice at the end of their treatments as well. It's, I guess, something that I think you touched on earlier. You need to sort of find your limit. You need to almost burn yourself out and then just dial it back a bit. And if you want to increase how many people you're seeing in that hour or over the day, well, yeah, it's something that, like anything, you need to have that gradual exposure to.
Yeah. I think there's also a degree of comfort that comes with time. And so the more years you're at something, it's like driving a car. The first time you drove a car, how many things were you focusing on? It was, you're exhausted by the time you got out of the car. You're like, thanks, Mum, for taking me out. I'm going to go over and lay down now. But now you can get in there and almost not even have your eyes open, and you can just do it all, right? And so clinical reasoning, or the work we do clinically, isn't the same as that. But I think at a certain point, you can start to pick cues almost on autopilot. If you don't want to be completely on autopilot, you can observe more without having to focus on more.
Yeah. And
then maybe with time it gets a little easier. We hope. We hope, right?
And having that kindness for yourself and understanding, and the humility too, to recognise that we're not going to know everything now, especially if we're learning a new skill. Any new skill takes practice and time. And I know you'd agree, what I know now to what I knew 20 years ago, I couldn't have imagined I would have ever been able to do the things that I can do now in practice. But experience is something that you cannot rush. That's something we all have to learn. And I think the last year, and I know you'd agree, Dalton, working with you and Bo, I feel like I've gone back to kindergarten again, and we're learning so much more new information, like learning how to teach as opposed to being a practitioner. And so you put so much pressure on yourself thinking, I should be doing a better job. But again, it's experience, and you can't pay for experience. You have to experience the experience. You have to do it.
Yeah, great. Any other points?
Yeah, last one I wanted to wrap up on was talking about understanding pain.
Okay.
And that leading into, I think, a few other sort of avenues of why it's important to understand what pain is. So sort of a bit of context with this point. I was reading a study as sort of getting into fascia, the role it plays and the characteristics, but within that they mentioned an International Association for the Study of Pain. First time I ever heard about it, blew my mind that we have an international association for it. So I read into a little bit more about that and came across that they have a definition of what pain is. Prior to that, I thought that oppressed, and I just experienced the pain here. There wasn't anything neurological about it. It wasn't higher order. Realizing that pain is a physical and emotional experience. And if you take one of those away, it's not pain.
Right.
Yeah, so that took a while for me to sort of grasp and understand, and completely change the perspective I had with the clients when we were addressing their pain in terms of the communication around it, why it feels worse on some days than it is others, and touching on to the language that we were talking about before. And arthritis, as an example, damage doesn't equal pain, and pain doesn't equal damage. And if you can't understand that pain is physical and emotional experience, then that's the concept that you struggle to grasp.
Yeah. And that's such an important point too, because if you don't think about the emotional component of pain, it's hard not to think about the patient like a machine.
That's right.
Like you can just look at them, this tissue, that ligament, that bone, there's the damage, that's the source of your problem. And if we just focus on a patient like they are an object or they're the structure, we forget the functional component of that. We forget the human that's attached to their very human experience. And so then you can just start addressing symptoms and not address a person. Whereas if you recognize there's an emotional component, you realize there's an actual human being there. And what can I do to help that human being have a better experience in their body, in their life? And now you're more than just a technician, you're a clinician. Like you're actually doing real work.
Yeah.
And so that's pretty cool.
And we joke about, the issue isn't in the tissue.
The issues are not in the tissue.
The pain is in the brain.
Sometimes.
And And even though we might joke about that, that can be a real reality for some people.
Yeah.
When we're treating someone and there is literally no physical reason for there to be pain, well, we need to be looking outside of that. But again, I was saying, we never learned anything about the fact that pain could be anything other than damaged tissue or an injury, or there had to be a definite cause for that pain that was physical.
Yeah.
But now, obviously, we understand that pain is just so much more than a sore, tight muscle or a sprained ankle. Or, yeah.
Yeah. And this idea of understanding pain better is I think what we need to build as a foundation to then be able to sort of move and work into like a biopsychosocial model. You can't understand that if you don't understand that pain has an emotional aspect. Getting into central sensitization, which we have a lot of information about through our courses and through other webinars. And then also things like predictive processing and more of a, I guess, updated model of what pain is.
Yeah. I think this is such a useful exercise, is to reflect back on the things that you wish you'd known earlier, because it highlights the things that are most important to you now and things that you can double down on getting even better at now.
Yeah, that's right.
You know, reflection, such a useful thing to do. It doesn't matter what the thing is that you're experiencing. It's like, think back, like what have I learned along the way? What's been the most valuable? What can I put more time and effort into now so that I can be even better when I'm reflecting again in 20 years or 10 years or 5 years or whatever the time period is. So, yeah, hopefully everyone who's been listening to this is taking something away from these guys. They've both had some really interesting and useful experiences in the time that we've been working together. I've learned a lot from them. Hopefully they're learning a lot from us. And hopefully you guys have taken something from this conversation that you can go, yes, that's the thing I need to focus on as well, because that's a gap for my knowledge. And hopefully make use of that too. So thanks for this. Cheers.
Awesome. Thank you.
Thanks for joining in. Bye.
Bye.